And are you okay for a minute, everyone? You're just going to look up at the screen. I just want to show you a couple of other things. I think everything in surgery is about displaying your anatomy properly so that you can understand what's going on and get a good view and the kind of setup for the surgery. And something I found helpful in the switch, you can see here, I put a stitch in the left atrial appendage and I bring that little stitch underneath the heart to flip the left atrial appendage out of the way. So you've got the appendage out the way of the great vessels when you're doing the switch, and the same with the right appendage, you can see, and it gives you a nice view of the great vessels. But I think setting yourself up is crucial. Displaying the anatomy is crucial in every single operation you do, whether it's a switch or an adult valve replacement. Get everything displayed so you can see it well. So think about what you want to do and get yourselves a system where you can get things nicely displayed. And the switch is a really good example of a whole series of steps that you kind of tend to protocolize in your head and you go through in your head before you do it. So getting everything displayed is really important. Okay, yeah, so carry on with your mobilizations. Let's say what I was saying them about. Can you see? You can see where the commissures are. Can you see?
Oh yeah, yeah. Now I can.
Well, they show it pretty well. So if you've got curved scissors, you actually, yeah. Go on,
and you said you're going straight
you actually you head straight for the commissure.
Yeah.
As if almost you're going to hit it. Yeah. And you actually curve your scissors outwards, so the whole kind of sinus comes out with you. Yeah. Then if you then change your hold and take this, then again, I'm heading for that commissure at the back.
Oh, gotcha.
Yeah. Yeah, and then you see it all starts to kind of fall out as you get down and through. You've got to watch for you.
Oh, I see. Then you have your ostium right in the middle there.
Yeah, exactly, and that's what you want. Yeah, and often you have to do a little bit of work just to mobilise this.
Mm-hmm.
You can see that they've got a little bit of there. See, but there's your coronary there, so sitting on its mobilised there. Yeah, and then the same. So we're going to do the same with the left. So again, just hold it open, and again. So what I do is head straight for that commissure there, straight down, with my scissors curved away. Yeah, and then the same here at the back. So you end up this rather narrow little pillar.
Oh wow! Okay.
At the back, which has got the commissure between the left and right coronaries on it, and then out again comes the button. Almost the entire sinus comes out with you.
Yeah, I don't think I ever appreciated how much you take with the whole sinus.
Yeah, and then you get these little attachments here, and it comes through, and then suddenly it's all free. Yeah. And then I'm just going to put a stay suture there first. Here to keep this all out of the way.
Is it common to have a small pillar like that?
Yeah, no, it always will have that, and that's fine. I will have time to talk about how you fix that. But you put a little sort of patch in to replace everything, to repair the sinuses.
Oh, I see.
So here your coronaries are sitting up in the air where you want them to be, and here's your pulmonary artery behind. And there's surprisingly little distance between the sinotubular junction, which is where the commissures end, and where the pulmonary arteries start. So you haven't got much.
I was going to say, I definitely never appreciated that either. You haven't got much room. I was assuming you had more MPA to go with.
Too low when you're right in amongst the valve. Too high and you're into the branches, which you don't want to be. So you really got that one spot, as you say, trying to make sure you cut it straight so it's perpendicular. It's also easily you end up with a sort of ugly oblique incision, which you don't want. And it's that sort of operation where everything has a consequence. So as Simon was saying, you cut this too short, and you end up with your buttons being too short, with no height to them. You cut it too long, and then you end up with all this redundant material, and you end up with an aorta that's almost too short for when you're reconstructing. So try and maximise the size of your button. That's you get the button right, and that's just going to be make the whole operation easy. You get the button wrong, and then the whole operation is going to be difficult. So all I've done is just taken out the coronary, so exactly where you were with a SAMI. So if you can see, so I say I've got my appendages out of the way to try and really display the great vessels nice and easily. We've got the coronaries nice and mobile on good buttons. And what you want the coronaries to tell you where they want to be. You're trying to minimise the amount of torsion or movement on those coronaries themselves. You're trying to let them tell you where they want to be, and not. So I don't like to overly mobilise the coronary, or it starts to be unstable and it's waving around in the wind. You don't know where it wants to be. So you want it to try and have its minimal movement from where it started. So again, your next step, once you've got your coronaries mobilised, is this important part about transecting the pulmonary artery. And there's very little room between the top of the commissures, the sinotubular junction, and where the pulmonary artery branches come off. So you have not got much choice of where to go, but it's so easy to transect the pulmonary artery at the wrong point. And we all do it, and they're frustrated. You do it too distally, and you've cut into the branch pulmonary arteries, and then immediately you've set yourself up for problems with branch pulmonary artery stenosis in the future. You go too proximally, and your route is too short, and you've got no room to put the buttons in, or you actually risk damaging the valve. So there's no great magic to it. You just have to make sure you get it at the right point, and if you can, just try and keep it longer rather than shorter. So you can see where I am, and again, it's concentrating on trying to transect it perpendicular to its long axis, which sounds simple, but again, so easy to end up with an oblique cut or not quite straight. So again, and so all these parts of the operation, take your time, see what you're doing. If you can't see properly, tell the perfusionist to drop the flow so you can see you haven't got blood in your way, and take your time and get it right, or you pay for it with making the operation more difficult for yourself. So you transect your pulmonary artery, and then I like to put stay sutures. I put 3 stay sutures, one to mark each commissure. And what you hope is that you've got nice alignment between the commissures of the original aorta and what's going to be the neo-aorta. They go partial thickness, but I put them full thickness in these models because the plastic's a bit soft. So maybe just a clip on it. Thanks, Rach. And again, just displaying everything, is so important. But all those variations in the switch are, there are those little sort of subtle variations, like the commissural positions. The exact course of the coronaries is so variable from one to the next. And in an operation like the switch, which is so protocolized, you're sitting in the back of your head going through all these steps. So from one side, you're thinking in a very logical, sort of planned way of each step of the operation, but at the same time, you've got to retain that flexibility that things might not be quite the same as you expect. So having that kind of extra little bit of wiggle room to know you've got to change things and assess the anatomy at each stage and alter it a little bit is a really key part of trying to get the best operative result that you can. It's easy to get tricked, and you resort to a fixed protocol and you're not flexible enough. So 3 little stay sutures go in, and they display the route for you nicely, and they're also marking you where the commissures are. So again, this is the open technique, remember, so we're not going to reconnect the aorta at this stage. Here's my left coronary. I always do the left coronary first, and again, you're asking it to tell you where it wants to be. And it almost always wants to go in the middle of the sinus, so exactly halfway between your 2 stay sutures. But it may not do. So take your time. Ask yourself, where does it want to be? So these are going to be medially hinged trapdoors, and you can see where the button wants to sit. Is that projecting okay? You can follow me, yeah? So you can see where it wants to be, and it wants to be pretty well in the middle, but you can see you want to set it high up. So you're going to have this redundant flap at the top of your button. It doesn't matter. So, yeah, so you're ready. So we can see we want to be in the middle of the, pretty well in the middle of that sinus, and you gently come down, pretty well straight down, that sort of length until you think you're about matching. You can stop and you check again, look for it again. It's probably about right. Yeah. So we'll go down a millimetre more, and then you medially hinge it. Yeah. So you change your position, and it comes median. Because you've got the aorta open, you can see your aortic valve cusps, and they're usually still actually just above them really, but a little medially hinged flap. You see. So there's the little flap. That's the medial incision, and your coronary. Can I borrow one of your forceps there? And your coronary is going to sit. It's kind of being received by the flap, comes out to meet it. So you're trying to get the coronary to sit in its most comfortable position. Yeah, it's going to sit in that little sort of U-shaped groove that you've created. So then you get your suture. I say people do it different ways. I tend to start at the top and looking. I say you can judge from your button, as you said. It's not going to want to. You're going to leave the top bit sitting free. Probably we want to start about here, and that's going to be the top of my button. So I usually start with the left, yeah, and then you can just run it in. But trying so all the time, you know, the fact you've taken a good button makes this bit so much easier. Suddenly, if you're in, you know, if you've got your orifice is too close to the edge, suddenly this becomes very difficult, and you're worried you're going to twist or distort the ostium itself. So you're running your button, then you can probably let it come straight down. And you want it to sit up in the air. So I say usually the coronary sits high. So the advantage, I guess, is that you get a nice view of the valve, and you know that you can see where the button is sitting relative to the valve. But you haven't got the aorta filled up in its natural position like it is with the closed technique, and I think that's a big advantage of the closed technique. It really shows you the natural position of the filled aorta, where here we've got the aortas flaccid and empty. So you've got to be confident you've got it right.
One thing I would say is when I watch people learning, or maybe haven't done as many switches, is take too many bites. I once had a staff guy tell me, take fewer and fewer bites until it started bleeding, and then you know that's too few, and back off a little bit on that. So just something to think about when Norwoods and switches have a lot of suture. And you can take the same stitch speed and have a very faster operation if you're taking fewer stitches.
So there we are. You see, we're almost at the bottom now already of the nadir of the apex, and here you should change your direction, and then you can start to sort of fold the button into the sinus and work up the outside. And you can see you're going to have the button sitting proud at the top. So this is the kind of medially hinged flap we're talking about. But you can see because you've taken a nice button, your sutures are nicely well away from the ostium of the coronary, so you feel confident you've not had to encroach on it. But of course, again, comparing the two techniques, because you leave the button sitting at the top here, you've got a lot of extra circumference that you've created to the superior suture line, and that means you've got more mismatch when you're putting them together. So the worry is maybe it disrupts your sinotubular junction, and the patients are more at risk long term of aortic regurgitation. And I can't say anyone's proven that really, but it's a potential risk. So can you see there it is sitting with its medially hinged flap, and hopefully in a nice natural position with the coronary sitting up proud. Always look inside, take a probe, pass the probe down the coronary, be sure you can see a nice clear pathway. It should be very obvious. And you can then lock your sutures at the top, or you can just leave them and you can lock them when you come round to finish off your suture line. So the right, we'll leave those there. Let's have the scissors again. So the right is exactly the same. Yeah, you're again trying to have things in their natural position. You're asking the coronary to tell you where it wants to be, and almost always it's in the middle of the sinus. There it is, where it wants to sit. And this again is a sort of medially hinged trapdoor. Again, being open, you can see where the valve is. And this is the sort of medially hinged. Let's get my state right to get that out of the way. But again, it's kind of medially hinged. So you just wander down the sinus and you can hinge it in there when you're happy. But again, check it with your coronary. Are you happy that's the right height?
Let me bug you a second.
Yeah.
And talk about commissure mental alignment.
Yeah.
So let's say the commissure sat exactly where you're cutting right now.
Yeah.
Tell us how you think about how to manage the coronary
Yeah.
in that situation.
Yeah, so exactly.
So it's exactly where you want it. You either have to go higher, posterior, anterior. Those are your three options.
Yeah, yeah. So you've got to, exactly that. Yeah. So you've got to work out if things aren't as you wanted them to be. So how are you going to be able to manage it? I think often the coronaries do sit high, so you've got a little bit more leeway. You may find you can even sit the whole coronary button almost above the commissure, so you haven't got to worry so much. But usually you've got to make a decision. Am I going to put it, which side of the commissure can I do it when it looks like they both want to sit, in the same one? So you really again just got to look at that anatomy. Having it open does help, I guess, because you're very conscious of where the commissure is and how it is. But usually you'll work out where is it going to be most comfortable. Usually sitting the coronary up high is very important, and it'll help you and get you out of trouble. Keep it up high. So up high, but yeah, towards the head, yeah. And then, but you may have to just you've got to make a judgment. Are you going to bring it medial or lateral to that commissure if the commissure is in the wrong place? So if you had a choice and you thought it was equal, would you go anterior or posterior? Usually it's anterior. I think that's it. Yeah. So you may even end up with, it's possible, occasionally if it's complete malalignment, you may end up with both coronaries put into the same sinus, with two incisions in the same sinus. And that's always worrisome. Yeah, the mistakes I've made in placing coronaries whenever I see those two kissing, both coming off the anterior sinus, it always is a big worry for me. Yeah. Occasionally they'll stretch, if the cert comes off, they'll stretch the cert if it's coming off anteriorly. So certainly if there's a cert there and you had a choice between going anterior and posterior, and you can't do it cephalad, then I'd probably choose posterior. But. Yeah, and there's a very interesting sort of story of in Necker in Paris. They went through a period where they tried actually deliberately joining the two buttons together and putting them into a single incision anteriorly, and they abandoned it because they had so much trouble with the coronary. So it just, again, it goes to show that usually trying to do that doesn't really help. You want the coronaries to be separate in two separate incisions. Yeah. So here, sometimes nature doesn't give you what you want, and you got to figure out ways around. Yeah. And again, so you see, here's the right again. Here's the little medially hinged flap. Here's the right coronary. So again, it's kind of starting it and usually lifting it up. So you often, again, start off leaving some of the button north free, because the crucial thing is to get the coronary ostium exactly where you want it. And it's usually a bit awkward, this first part of the right coronary, because you're kind of working underneath yourself. So until you've come down the first side, it's a bit awkward. So just back to the previous topic, you can also mobilize the coronaries more, which can be helpful in dealing with that problem. Yeah, exactly. You may open the aorta and find it's a bicuspid valve. It happens. Yeah. That's when you call the cardiologist into the OR just to point it out to them. Just because it makes you feel better. Yeah, of course not. But it's a good point. People often say, oh, it's somebody else's fault. It's nobody else's fault. It's your fault. You're the surgeon. You've got to have been comfortable with what you'd seen on all the data beforehand to be sure you knew what you were doing. So you can't blame anybody else. So again, coming down to the apex, and once you get to the kind of nadir, the lowest point, which is hopefully the closest point for the coronary, again, you can then change direction, you move your stay suture, and suddenly everything's displayed nicely for when you're running up the other side. Again, always grateful that you took a nice big coronary button. But when we join the aorta together, you're then going to have to be aware of that mismatch in size between the proximal and the distal circumference. So you're going to have to make that up as you go along, as it were, near and far it as you go. I know some people will kind of do a mixture of the two techniques. So you do it open, but you do the Lecompte maneuver first, and you join the back wall of the aorta together first to try and lift the neo-aorta up straight, so that you've got a better idea of how they're all going to sit at the end. So if you follow me, there's the right coronary coming in. Again, the medially hinged trapdoor. Okay, so there's the right coronary, and I hope you can see that there, the two coronary buttons, the coronary sitting up nice and high. You should be really confident they're sitting right up there, and you know they're going to be wide open. So get a little probe down and be sure you're straight down the coronaries. You can see where they are, and now you've got that reconstructed aorta, but you can see you've got a much bigger circumference to manage, and you can either cut these longer lengths of button away so everything's flush, or you can make a counter incision into the aorta to accept those buttons as you come around. Okay, everyone, we'll kind of have a little break again. Pretty good, some pretty impressive coronary implantations I've seen around the room. That's nice, and I think, it's nice to see. I think a lot of you really grasped the concepts and focusing on just getting those coronaries in the right position. So, but we can look at all the other kind of components of the operation. The coronaries are obviously the key, but also you have to be able to reconstruct the pulmonary artery as well. So you've got some patch material. So again, if you look at the screen, usually I think pretty well everybody will use autologous pericardium to repair the defects in the in the original aortic route where the coronaries came out. And typically you start off with a piece like this, that you can see here, with a kind of rectangular piece of pericardium. And usually I just keep it in its natural shape to begin with. And you're going to shape it kind of as you go along. But you usually end up with like a pair of short trousers is the sort of shape that you're going to need. And you've got to repair those sinuses. And again, people do it at different stages of the operation. I do it actually quite early. So I do it as soon as you've taken the coronaries out. The next thing I do is I put this patch in to reconstruct them. Then you can pull the patch out the way and your job is done. So you've usually got your pericardial patch, and this is 3D printed patch. It's a bit thick. But if you see, I've just come through the patch, and then here's the original aorta. It's going to become the pulmonary artery with those little valves. And remember, we took those buttons out, so you're right down onto the valve, and they usually start just at the top of the commissure there. Oh, okay. Have we got a shot? And then you're going to use the patch, and you want this patch to be absolutely watertight. So as you come down and you're coming into the sort of floor of the heart very quickly, you want to take good bites of the pericardium, so it's like a washer, and you can get good bites here. There's nothing to worry about. All you want to do is make sure you spare the valve. So we can probably go down with that now. Pulls the other way. And again, even sometimes, I think you'll see it here in the model, your suture almost, your needle almost comes out in the ventricle, and you just bring it back through the annulus, so you spare the valve leaflet. But you want to be sure you've got nice hemostatic stitches.
So you want to make sure you don't catch adventitia of the coronary that's close by.
Yeah.
That can cause coronary ischemia, so watch for that.
So hence the importance of mobilizing your button properly as your first maneuver, so they're well out of here.
And then the other thing is you're creating this patch. Once it's reconstructed, you want to make sure it's not pushing on the coronary buttons, because it can cause flow acceleration on echo.
Yeah.
And some of that has to do with where you position the coronaries initially. If you get them off the midline, it's less likely to be pushed on.
And again, some people do this at the end of the operation or when the cross clamps off, but it's a bit messy. You've got blood everywhere, and I like to see what we're doing and have the heart quiet. And as Glenn says, so that there's no risk that you're catching the adventitia or going to distort the coronaries. I get this all done at the beginning of the operation. So as you start to come out from the base of the heart, if you can follow, we're coming up towards a funny little pillar that you have. Yeah, we'll take that out in a minute. So as you start to come up that column, so be careful because this plastic's a bit thick. Yeah, the stay can go. So that's when we just stop and use the scissors, and you can cut off the top of the little pillar because you don't need it. That's no help to you. That goes, and then you make a sort of a relieving incision into your patch. This creates your little kind of pantaloons, your little sort of short trousers. Okay. And some people put two separate patches, one into each sinus. That's fine. But usually by doing this, it gives you some height above it as well that you can use to give you more freedom of reconstruction for your pulmonary artery at the end of the operation. We just want to get this patch in safely, yeah.
So in the history of the Congenital Heart Surgeon Society, if I remember right, there used to be a lot of pulmonary stenosis.
Yeah.
And that's really where the popularity of the pantaloon patch came from, was there seemed to be less stenosis with the pantaloon. I'm not sure that holds up over time. There may have been other factors associated with that.
Okay. So here we are, just coming up to the apex of that little cut in the patch, and then you can sort of change direction. So see what I do. So then back through the pillar, out through the patch, and then you're coming now round the other side. Yeah. But all the time you're thinking about hemostasis more than anything, that this is going to be a really secure suture line, so you haven't got to worry about it bleeding at the end of the operation. So really good bites. And the fresh pericardium is very forgiving because it's nice and soft, and it'll just take on the natural curve of the tissues and fold with it. So it follows all the way around. If you've got no pericardium, say for some reason it's a redo, then you've got to decide what you're going to use, and it's difficult to find a nice substitute for fresh pericardium. Pulmonary homograft is probably the nicest thing to use. You can use bovine pericardium or cardiocell, it's just a bit stiffer. So yeah, so all the time, and even though you've taken your buttons right out onto the valve tissue almost themselves, you can still find good strong annulus to sew your suture line to. And once you've come out of the depth of the heart, you can stop and you can finish it all off at the very end of the operation when you're reconstructing the pulmonary artery. Right. Okay, so pretty well there. We can probably, so you get the idea. I hope you can see your valve there. If this is a bit sort of sunken in, you can resuspend it. You can lift it up with an extra suture and lift it up onto the patch like that. But what I find is because you've got this patch on, you can then fold the patch forwards, and it then displays your neo-aorta nicely to do your arterial switch with, to do the coronary implantations with. Okay. And you can trim your patch as you want to later on in the operation.